2/3 of people with epilepsy are controlled with antiepileptics, many times with the first medication that you give them that is appropriate for the type of seizures that they have. But there's that 1/3 of patients with epilepsy that their seizures are going to be very difficult to control. And you usually can tell when they have failed the second anticonvulsant. If you identify the type of seizure that the patient is having, you correlate that with the EEG, and you prescribe the right anticonvulsant, and the child is still having seizures after a second anticonvulsant, then you know this patient probably is going to be refractory. And at this point, things need to move on quickly, is my impression. The first thing that the neurologist should do is make sure that this child is not a surgical candidate, meaning that the seizures are coming from a focal point in the brain that actually you can go and take out and sort of cure the epilepsy. If your patient is not a surgical candidate, then you move on to things like vagus nerve stimulator or the ketogenic diet. I mean, people may go and try many other anticonvulsants, and I think that's right. But I think after you fail the second medication, you want to know, is my child a surgical candidate or not? If it's not, should I do VNS or should I do ketogenic diet? Not everybody is a candidate for the ketogenic diet because it's a quite an extreme diet, and the discipline on what you allow your child to eat is quite intense. And Jessica will be telling us about that. It is a wonderful therapy, though, if you are able to do the diet. This is probably a little bit easier to do. Now, the vagus nerve stimulator has been around for a long time, 16 years. And I love this device, and probably because I was very lucky. 16 years ago in 1997, when VNS was approved at the FDA, I had a patient who was a 10-year-old boy who came to my office with tonic seizures. And this child will do this all day long, and he will do it during his sleep. This is a form of generalized epilepsy. The medications that I initially gave him did not help him. Then he was allergic to some of the other products. So this child for a few months was convulsing, you could say literally day and night. I refer him to Boston Children's Hospital, and I say, is there any chance that this activity that appears to generalize everywhere in the brain could be focal? Could he be a surgical candidate? They admitted him. He spent there 5-6 days, and they say, no, this is a generalized seizure disorder. I knew that. I just want to give him any benefit of the doubt. And they said, this has been approved. Why don't you do that? So obviously, that an electrical device that you put that goes through the vagal nerves and is going to end up in the midbrain is going to control epilepsy. I was very skeptical, but the family and I have nothing to lose. So we say, okay, we'll go with this. And this kid really won the lottery. By 3 months, he was seizure-free. And I was totally sold out on this. I said, this can help seizures. And he has done quite well. So that's how I started using VNS. And I am probably one of the people in Rhode Island that use more VNS than anybody else because I had that my first experience. Now, the incidence of seizure-free with VNS is low. It's only 4 to 5%. But in this particular patient, was 100%. I have had experienced that with other patients, but the numbers are still below 10%. In my practice, it's about 10%, but I think it's 4 to 5%. So what is VNS? So basically, you can see this little generator is implanted on the left side of the chest. And the patient usually gets 2 incisions, one on the chest, one on the neck, because the electrode needs to go in the vagal nerve. That will take the electrical impulse into the midbrain. And you can activate, you program this. So you decide how often the impulse is going to happen, for how long, and how frequently. And the doctor, the neurologist, will do that. So basically, this is what we do. Now, the response rate is, this is the kind of device that usually you may not see anything for at least 3 months. But after 3 months, you may start seeing some response. And usually by the end of the first year, you are seeing really good response, which is about 50% seizure reduction by the first year. So first year and second year, that's what you get. And that's probably what most anticonvulsants are. Anticonvulsants that are approved by the FDA, they have to show at least a 50% seizure reduction. So this product can be as good as an anticonvulsant. Now, we have a lot of data now because kids who get implanted, when the battery runs out, they want to be replaced. They want the battery replaced. So we have a reimplantation rate very high, about 70%. And so we have data now for at least 10 years. And it's looking that the longer you keep this device on, the better the numbers get. So by 10 years, the seizure reduction is down to about 75%. So the longer you stay with this device, the better it gets. Some patients, the numbers are looking really good for patients with Lennox-Gastaut. Do we have anybody here with Lennox-Gastaut syndrome? It's the child who starts with infantile spasms. These are very difficult seizures to treat, and they move on into a very refractory epilepsy, where these children have different types of seizures. They have tonic seizures, they have drop seizures when they just fall, they have generalized tonic-clonic seizures, and these patients actually are doing very, very well with VNS as the years are going by. What is also very good about this device is that we give the parents and the patients, if they're older, we give them a magnet. So they are actually able to activate the electrical impulse when they need to. When would they need? If the child is having a seizure, you can swap the generator and you get an impulse. And that many times helps to get the child out of the seizure, or at least make the seizure shorter, and sometimes the child recovers a lot faster after the post-ictal state, after they're having a seizure. So many parents, even when they are not having the greatest control, they will tell me, I love that. I love the fact that I'm able to sort of maybe stop the seizure, maybe decrease the amount of time that the child is going to have the seizure, and make the post-ictal state a lot shorter. So that is a great benefit. Well, it says in there it's not brain surgery. It really is not. It's an ambulatory procedure. My patients usually go in for the day. The whole procedure lasts about an hour. We have very good neurosurgeons in the state who can do this very easily. The patient goes home at the end of the day with 2 incisions, one on the neck, one on the chest. And again, 70% of patients go back to get the battery changed. This generator has a battery, is attached to a battery that depending how you program the impulses to go, it may wear off faster or it may last longer. So in some patients it could last 5 years, in other patients could last 8 years, in other patients 10 years. So it comes a time that we say, do we need to change, do we want to change the battery? Do we want to do this? Actually, this device now, this is the actual size. When 16 years ago we started doing this was a lot bigger. So it has become a lot smaller and lighter. And basically, what I do is once a patient is implanted, I usually like to activate the patient after 2 weeks when the 2 wounds have healed completely. And at that point, we activate the patient. And then the patient will come into the office every couple weeks until I get them into a setting that I like. And then after that, every few months. Most of the time, I start seeing some differences at about 3 months. One thing that I have to say about this is very well tolerated. I always was concerned. I mean, how bad is it going to be? The most complaint that children have, and actually they don't have a lot of complaints, it's just that when they're speaking, their voice gets a little bit hoarse, and sometimes they talk. But they usually adjust to it, and it is amazing how quickly they forget about it, to the point that sometimes a child comes to me, to my office. Every time they come, I check their VNS, and for some reason it's off. And they don't know. They didn't realize that the generator went off because they can tell me. So kind of scary. You know, it's good that you know, but at the beginning they know when it goes off, but sometimes they get so used to it that even the generator is off and they haven't realized that it's been off, which is not good because sometimes they have seizures. So they can get a little bit of coughing, a little bit of tickling sensation. I never had anybody with shortness of breath. One child who rides a bicycle, like 1 or 2 miles a day, you know, would complain about that, just one patient. And what we did is I told him, when you exercise, tape it. You tape the magnet and you turn the generator off. So he could do his mile of bicycling every day and he didn't have any problems. More than 65,000 people over the world have been implanted with the VNS. What I like about this is that it's not a medication. Many of the patients who have refractory epilepsy, what's like some of your children, may be on 2 or 3 medications. And medications can be very sedating. They can have a lot of side effects. And I find it that at least you don't need to worry about that with this. So if you can get away with 1 medication and VNS or 2 medications and VNS, I think for my patients, I always think is a gain. You know, less medication is always good. This does not interact with the medications. It's safe for pregnancy. I have one patient of mine who became pregnant while she was on VNS, and she did fine. The baby's perfectly normal. There's data about this at this point too. And it really doesn't have any interactions with anything. SUDEP, you know, death in epilepsy, there hasn't been any increase in that. As a matter of fact, you will think that this is probably helpful, though there's no data about that, VNS being helpful for that. Another thing that I think is a big benefit about the VNS is that it makes the patient more awake and more alert. And this is regardless if the epilepsy is better controlled or not. It's just a benefit that you get from this medication. And I really like this because many of my epileptic patients who are refractory and a lot of medications can be very sedated, tired, down, you know. And I had one case that it was amazing to me. It was a teenage girl who had generalized epilepsy. She wasn't a surgical candidate. She was on 3 medications. We put a VNS on her. And when she came to the office, she'll be totally ragged, and she'll just come like this, and she'll sit there, and half the time she was drooling. I don't think she knew where she was. It was pretty sad. And nevertheless, I decided that I was going to do VNS for her, and we did that. And every visit that she came, she looked a little bit more groomed. And after like 6 months, it was a regular, typical teenager. You know, her regular jeans, the jacket, the jewelry, the lipstick. I was like, oh my God, what happened here? And it was VNS. I couldn't believe it. I couldn't believe it. So really, I really, as you can see, I love this. I probably have around 40 patients. Some of the patients have moved out of state, so I lost it. But I really think this is a really good product. I think is underutilized in some regions of the country, and I think in Rhode Island is underutilized. So ask your neurologist, could my child be a candidate for VNS? Don't be afraid of it. That's the other test that VNS passed for me. I had an autistic kid with seizures, and he was a candidate for VNS. And I don't know if you have any children with autism, but they have sensory integration issues, so all their senses are very enhanced, incredibly enhanced. Noises are louder than for everybody else. Tastes are much worse than anybody else. everything. So I was thinking, my goodness, what are they going to feel when they had that tickle in the throat? I was very concerned, and that child has done very well. Not a problem at all. So I think what they feel is so minimal that really is not a big deal. What else do I have here? Cybernetics makes VNS have an amazing amount of support systems that you can use. If you are considering VNS, Mike will come and talk to you. You could talk to a nurse practitioner. You could talk to another parent. I mean, they have an amazing amount of support. They are wonderful getting magnets, when the parents lose the magnet or the school wants a magnet, and we're always passing magnets around, so they can also be used at the schools. There's one thing with VNS that you have to know is that you can getting an MRI and having VNS can be an issue. You can get an MRI of your head as long as you turn off the generator, but you should not get an MRI of the rest of your body. You can get a CAT scan. So that's usually the only drawback that I see on VNS. But besides that, I think it's a wonderful device. I think you as parents should be informed about this and use it. I think the major reason why neurologists don't use it is because they never use it. And just the idea that an electrical device is going to help seizures, it amazes me. When I go to epilepsy meetings, just when I was in California, they have the Child Neurology Society meeting, and then they have the Epilepsy Society meeting, and VNS data is an explosion. I mean, it's everywhere. Everybody's using it. But you get pockets in the country where really it doesn't seem to take off. When Mike asked me if I could do those, I said I'll be very happy. I'd like to inform parents that they should be aware of VNS because it's really something that I find very helpful. And there's an explosion of new devices that has to do with electrical impulses. So right now, deep brain stimulation to help with epilepsy, actually Dr. Gaitanis didn't mention that. I thought he was going to mention it, but he didn't. It's been approved in Europe. Deep brain stimulation is being used now for Parkinson's and dystonia. And there's a huge studies going on around the country now for epilepsy. It hasn't been approved in the United States, but it has been approved in Europe. And there's a whole collection of devices going inside the brain and outside the brain that are going to be able to pick up when a patient is having a seizure, will get activated and go and try to stop the seizure. So the electrical treatment of epilepsy is here, and I started really with this little device, but none of these things are available just yet. Anybody has any questions? Go ahead.
I see that it's an electrical current is delivered to the brain, but how does that actually, once the current's delivered, what does that do? What's the...
Well, I mean, people trying to come up with all these explanations, but to be honest with you, I'm not sure we know. It goes to the basal ganglia. There's one particular ganglia that is called the thalamus that we feel regulates brain activity, and I think it works at that level. And there's people that think there's a different ways that it does it, but I don't think it's very well understood. But we know it works.
Can you see it on an EEG where it will does it literally change the brainwave?
No, you don't see it, no. And that's why I think, there was so much skepticism about this. In my case, I was pretty skeptical myself, but when I saw this kid seizure-free, I just couldn't believe it. I said, this stuff works. Oh my God.
Yes, that was sort of my question, the neurophysiology. So it seems as though we have maybe some gating at the level, at the thalamic level.
Yes.
With regards to the basal ganglia, doctor, do they know exactly where in the basal ganglia, the cardiac containment?
Well, I think it's mostly the thalamus. I think.
Okay.
I think we always have thought that the thalamus regulates brain waves, always has been the idea. And I think somehow it's helping to regulate. And that's what it takes a while really to help. It takes time. Yes.
What's the youngest patient you've recommended a VNS for?
Actually, the FDA approved is 2.5.
No, it's still 12.
It's still 12.
Yeah.
Okay. Well, I as Dr. Gaetani said, I've done babies. I did like an 18-month-old baby. The insurance companies do pay for this, but in child neurology, everything that we do is really out of FDA approved, because all the medications are usually approved initially for adults, but we move on and use them in children. The same thing with these devices. So my patients are all ages, but I had an 18-month-old, and I have a lot of young children that have been implanted. And you know, epilepsies tend to be the worst under 10, so most of my patients were under 10 when they got implanted. Yes.
So if you do the surgery for a younger child who's growing more rapidly,
Yes.
do you need to replace it prior or upgrade it prior to the battery going there?
Yeah, I mean, at some point the battery will have to be replaced,
Yeah.
you know, so I imagine they may make some changes at that point if it's necessary. That has never happened.
Okay, so it wouldn't be a more frequent replacement just because of the child growing more?
No. Actually, I've never had that happen. The only time to really go back is just to replace the battery. Yes.
What about other sports? You mentioned biking, but what about swimming, baseball, soccer, anything along
No,
those lines?
you should be able to play any sports. Yes. Actually, it's very difficult to break the system. You know, the generator is here, and you have the cable and then the lead that is in the vagal nerve stimulator. Occasionally, the lead could break or something could break, but believe me, it's not easy. In 40 patients, I had one who managed to break the lead. But that was a patient with Lennox-Gastaut that was totally hyperkinetic, and he had the drop seizures. So he was falling all over the place. But I have other patients with that, and it's never happened. As a matter of fact, I have a patient right now who is big, and he's very hyperkinetic. And I'm thinking about doing VNS. We're going to try ketogenic diet with him. Actually, we're doing it right now. Because he has a G-tube, and he really doesn't eat anything by mouth. So the ketogenic diet seems to be like the best choice for him right now. If the ketogenic diet doesn't work, I am planning to do this. And I asked Sandy Helmers, is an epilepsy attending in Emory University, and she's done thousands of VNSs. And I asked her, could this kid break this? Because I really don't want to do it. And she said, Maria, put it on. It's very, very difficult to break this. Yeah.
So I've come across a lot of kids with the VNS, and some of them have it in the chest, and other ones have it in the armpit. Is there a significance to the difference in location?
No. As long as you know where it is located. I mean, people should know, family and teachers and nurses should know where the VNS, the generator, is located, and the best way of doing it is palpating it, feel it, find out what it is, and then once you know, that's where you're going to be.
I didn't know if there was like a reason they chose to put it in the armpit.
I think the neurosurgeon at the time decides, you know, what would be the best location that would be better for the patient, that is less obvious. I mean, this is a small and it's really not very obvious physically. I mean, the child doesn't look deformed or anything like that. If it's a girl, it's even better, you know. Very good. Oh, go ahead.
Does it work better for patients that have, you know, where you know where the origin of the seizure is coming from, like deep-seated in the brain or on one side of the brain or the other, or does it just kind of help everybody?
It helps everybody. But for that type of patient, the patient is not a surgical candidate, but there's one area of the brain when they have identified where the seizures come, there is a device that will be placed inside the brain, will pick up the activity when the neurons are ready to discharge, and right before the seizure happens is supposed to avoid the seizure. That is in the works.
That's something in the works.
Yes, it's not available now. Right now, the only thing that we have available is the VNS, and like I said, it's been around for a long time, 16 years, yes.
Is VNS a good choice for a child with the absence seizure? Not severe, but enough to have to be on medication?
Well, I mean, absent seizures typically are easily controlled. I mean, you have a child who's not well controlled, who has absent seizures.
He's on medication, it's pretty well controlled, but there are a lot of times where there are seizures
Yes,
throughout the day.
yes. Is he on one medication or two?
He's on one, but he's also a little on the autistic spectrum
Yes,
side as well. So
Yes.
he's in a self-contained classroom and, so because of the epilepsy.
yes. I mean, a patient like that, probably I will add a second medication. I mean, you obviously want to avoid any clinical seizures. I mean, absent seizures are funny. When you look at them on the EEG, it depends how long is the burst on the EEG. When the burst is longer than 3 seconds, you may be able to see it. If it goes from 3 to 9 seconds, you most likely will see it.
That's what it is.
So he's
That's 1 to 10
bursting.
seconds.
Okay, so in a case like that, I will add a second anticonvulsant. And if the second anticonvulsant still doesn't work, yes, he probably is a candidate for VNS. Yes. Okay.
Thank you so much.
Thank you.